A patient who ended up in retrospect having low blood sugar was misinterpreted as having high blood sugar. Patient got more insulin and went downhill, had to be intubated. Nurse leader, along with their HR partner, suspended the nurse involved. Within 2 weeks, we had another very similar event on another unit. And at that point, the chief nursing officer of the hospital called me, and indeed, we did the review, and we found many, many system components, including a major design flaw in the glucometer that really led to misinforming the staff about the glucose level.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Today, I'm joined by Terry Fairbanks. Terry is the Chief Quality and Safety Officer at MedStar Health, where he leads system-wide efforts to improve patient safety, clinical quality, and reliability across a large academic health system. He is also the founder and founding director emeritus of the National Center for Human Factors in Healthcare, one of the most influential efforts in the U.S. to bring human factors engineering directly to the design of healthcare systems. His work sits at the intersection of medicine, engineering, and safety science, shaping how organizations think about clinical workflows, system design, and risk. Earlier in his career, Terry was a paramedic and is also trained as a human factors engineer, which gives him a unique perspective on healthcare that's both deeply practical and systems-oriented. His work has been recognized nationally, including with the John M. Eisenberg Patient Safety and Quality Award, one of the highest honors in patient safety. He's also been part of national conversations, including conversations at the White House, on how we learn from harm and improve safety at scale. What I was particularly interested to explore in this conversation is how Terry's thinking has evolved over time, especially through work like Annie's story, which we'll get into, and how that's led him to challenge some of the core assumptions we make about safety, learning, and improvement in healthcare. Terry, welcome to the show.
Thank you. It's great to be here.
I wanted to jump right in. If you could give me a bit of a zoomed out view of what brings you into this space. What's your background that has led you kind of to this point?
Well, it's a great starting question because I have an unusual start. It's hard for me to have mentorship discussions because I didn't plan this out, but I started as a math and physics major. I was a math and physics major in undergrad, and then I went on to get a master's in industrial systems engineering, the whole focus on human factors and safety engineering, really. And my funding in that degree was in safety science. And in that decade, it was really, in my 20s, I was immersed in safety in other industries. I had very little to do with healthcare, except for the fact that kind of on the side, and part of the way I paid my way through grad school, I was a paramedic. And I did it volunteer and paid, and then kind of tied my background in because as I was getting near 30, I started working in an ER to become a better paramedic, basically part-time. And I loved the ER so much that I decided to do a career change and see if I could get into medical school. And I really, at that point, thought I was walking away from safety science and that background, and it was going to be a new career. And then I got in healthcare and really realized there was this deep disconnect, that the stuff I had just spent the last decade doing in other industries wasn't really fully recognized in healthcare. And I was interested in transportation. My first decade was a lot of transportation safety. I had gotten my private pilot's license. I had a real special interest in aviation safety. I had learned a lot about nuclear power safety, but I had not done a lot in healthcare safety until I got into it and became I went to medical school to become an ER doctor. I started working in the ER, and I really started to realize where the gap was.
Yeah, and we never know where those paths will lead. Certainly in retrospect, the edited version looks like you had a plan the whole way, but it sounds like it was an interesting journey as it unfolded. And so I'm curious, maybe if we can jump right into one of the things we wanted to talk about today, which was Annie's story. And this is a story that you've, I think, shared widely and maybe also in your invitation to talks at the White House as well. Can you tell me a little bit about what Annie's story was?
Sure. Well, I think I'll start by saying Annie's story is a 4.5-minute video that we created at MedStar Health about 15 years ago. And the purpose of creating it was meant to be an internal training program for our 2,500 frontline managers, people like unit manager, nursing unit leaders, vice chairs of departments, people that were the frontline managers, so that they could understand the importance of doing a full event review before taking a disciplinary response after an adverse event or a clinical event. That was the purpose of it. And so to give a little bit of background, starting with that and what our purpose and why we created the video, it's important to give some background on MedStar Health, where it was created, and why we got to this point. And MedStar Health is a 10-hospital system in the DC and Baltimore region. We have about 33,000 employees and about $9 billion annual revenue. So it's a good size program. And about 15, 18 years ago, in 2010, MedStar Health really went on a campaign to put patient safety as a very high priority. And in that, we had lots of kind of safety science-based, safety-oriented processes, including we did these special event reviews. We call them systems-based event reviews. We think they're better than the traditional RCAs in healthcare. We think they get us to a better answer. And in this case, this was back in 2011, we had an event happen in one of our big academic medical centers on a diabetes unit with a really good diabetes nurse, where a patient who ended up in retrospect having low blood sugar was misinterpreted as having high blood sugar. The nursing staff communicated to the on-call hospitalists, and they ordered insulin, and patient got more insulin and went downhill, had to be intubated and put in the ICU. Within 24 hours of that event, the local nurse leader, along with their HR partner, suspended the nurse involved once they saw from the lab that the patient had low blood sugar. And what happened after that is within 2 weeks, we had another very similar event on another unit, which went down similarly, but with a different nurse. And at that point, the chief nursing officer of the hospital called me. I was leading the Human Factors Center at the time, and I'll talk more about that in a little bit, but said, I think we need to do a deeper evaluation of this. I think it's more than the nurse. And indeed, we did the review, and we found many, many system components, including a major design flaw in the glucometer that really led to misinforming the staff about the glucose level. So the discipline was reversed. Everything was kind of smoothed over with that incident. But we realized that we had this world-class systems event review process that we not only did really well here at MedStar Health, but we were helping other systems learn how to do, but that it wasn't being consistently done, and that not every leader consistently understood the importance of activating this and activating our just culture policy and everything. So we created this video for that purpose. We never imagined that it would become a video that was used for that purpose by hundreds of health systems around the world. And we're really proud of that. It's funny. It's been so long ago now. I look younger in the video, but for a long time, I would go to national meetings and people would come up to me and say, "Are you in that video?" And Annie has become really herself the nurse involved. The nurse's name is Annie, and she's at first she didn't even want to do the video. It took a while to convince her, but she's now become somebody who's become a champion of this. We've brought her to a couple national stages. She talks now more than a decade later about how the event has impacted her. So we're really proud of the video. It's had a significant impact for many around the country.
Yeah, and I've seen it. It's a great video and a great example of how to do these investigations well. So what were the kinds of breakdowns, if you're able to share, that occurred in a case like that might individually feel small, but then can kind of all come together to make a really dramatic change in the patient's condition?
It's a great question, and the event review, we're actually making a second video that goes into more detail about the event review, because in this initial in the initial video when we produced it, our only goal was to show people the impact of not doing a full review. So we didn't go into the details. So there were several factors that we found, and it was interesting because to do the event review, one of the things we'll often do in our event reviews is simulation to really recreate the problem. And, in the morning checks of glucometers, how usually the nursing staff or the PCT staff has to check on a daily basis, do the QC checks of the glucometer, where they put the artificial fluid in and make sure it's within range. And what I didn't know, I learned during this event review, is that you can buy those fluids to check glucometers for high and low, but not for very high or very low, the critical high and critical low categories. There's no fluid available for those. So when we went to do the event review and we knew we needed to do a simulation to see what Annie was seeing, because she kept saying, I know it was saying that the blood sugar was high. I know it was. And everyone was like, well, how could it be? We're looking at the labs. It was low. We actually waited for a patient to come into the ED with critically low blood sugar, and we used a patient's blood. We went down and simulated it, and this was years ago, so we used our BlackBerry to videotape the actual glucometer. And what we learned was striking. The operating system of this glucometer was such that as soon as the result popped up, it popped up HI or LO, in this case, LO. And then immediately, right on top of it, a message appeared that it turns out in retrospect, the company did not design the message. It's one of those things that during implementation, they come to their client and say, what do you want this message to say? And this message said, critical value for blood sugar greater than 600, resend labs. And all that Annie kept seeing is greater than 600. That's what popped out at her. And of course, it covered up the LO, which was the message saying critically low. And this really brought out an interesting point. It's similar to EHRs. I've done a lot of studies in my past of EHR safety design. And when we looked at that, we concluded that from a human factors perspective, there were 3 problems with safety in EHR. One is the design of the product itself. The second is the implementation of the product. And the third happens in the actual use of the product, which can be impacted by the first 2, but that often can be from training and proper use of the individual. And this really applies in this medical device story because the vendor, I think, probably worried about liability. I'm not sure why, but they come to the hospital system and say, what do you want this message to say? And it's one of 2 pages of configurations that need to be done before implementation. And I'll just say a side note of what we've done since then is we've started asking vendors when we're implementing their devices, we say to them, you've implemented this device at thousands of hospitals. This is the first time we've ever done it. You're the expert in what these configurations should be. So we want you to tell us what the optimal configurations are. And it's interesting because some vendors are very reluctant to do that. Sometimes it's just that they think that the client always, everyone thinks they're different and they're special, and so they just want to allow that. But other times they seem reluctant, and I think it may be because of liability concerns. So I'm getting tangential, but that was one major finding, is that design piece. And when I talk about that, I talk about the fact that it wasn't just a poor design with the pop-up coming immediately to cover up the main message, but it was also the implementation problem. And it turns out we have 10 hospitals. We had chosen 5 different messages as we implemented these glucometers system-wide. And when we looked at that further, keep asking why. Why did we do that? It's because the vendor was asking the local lab manager at each hospital what the configuration would say, because the lab manager was the main client in implementing glucometers. And so that kind of follows into when we try to implement safety science and integrate it into our overall safety program as a health system. We always say that we should have a safety opinion in the room, make sure we have the right safety expertise in the room when we're doing implementations. So there were several other pieces to the event review. I'll just give one other that I think is really interesting. Is this was a diabetes unit. Diabetes units, the nurses there are deeply specialized and expert in managing diabetic patients. And Annie was a very experienced diabetes nurse. She was the one that was the go-to for doing orientation of new nurses. She was a well-regarded, great clinician, still is. But she had never seen a critically low blood sugar pop up in the glucometer because they're so good at managing. So we went back and we thought that was interesting. We went back and looked at the last 80,000 blood sugar checks in this hospital, and 0.1% of them were critical low, and almost all of those were in the ED with patients that came in with critical low. It's just not something we see. And so until this experience occurred, people didn't understand that this is how the pop-up messaging worked on the glucometer device itself.
I wanted to pause for a moment to invite you into something I'm starting with this podcast. If something from this episode connected with your own experience, where you've seen it work or not work, I'd love to hear about it. There's a short link in the show notes where you can share what you're seeing in your own work. It takes about a minute. I read every response, and over time, I'll be sharing what we're learning together in future episodes and in other ways, and giving shout-outs during future episodes to people in the community who share ideas that really move the conversation forward. If you're up for it, I'd really value your perspective. Thanks. I know you've also talked about with these event reviews that they need to occur, I think, with support of the people involved, but also to begin immediately, even before all the information is known. What happens to the truth of an event in the hours and days after it occurs?
I want to make sure I understand the question right. You're saying what happens to the truth?
Yeah, I guess why jump on it so immediately? What is the added value in that?
I see.
I'm curious
Okay.
to know your perspective.
Yeah. Well, let me talk about, first I'll just frame it in what we teach our teams as the correct response after an event. And first I'll say that we ask them to trigger this response based on what we call a serious unanticipated outcome. We even have an acronym, SUO. Everyone in our health system knows what an SUO is. The reason that we frame it that way is if we say to people, we want you to react to an adverse event or a medical error or a serious safety event, the local team always takes a little bit of time to figure out, is it one of those things? Because it's not always obvious if there's actually been an error or something that's triggered an adverse event or a violation of standard of care. It takes a little bit of time to get that information. And in the meantime, we realize that often the patient or their family or the clinical team members are uncomfortable with an unexpected event, and we lose that crucial time to respond. So that's the first thing I'll say, is that we say to our teams, anytime there's an unexpected event, an SUO is defined as an unexpected clinical event, either by the patient, their family member, or clinician, then it should trigger a response that has 4 main components. That, even just to make that point further, that even covers things that maybe in a surgical situation, a surgeon might say is an expected side effect or something that can go wrong, an anticipated complication or a known complication. So the clinicians may not actually find it to be an unexpected outcome, but the patient and their family may be. Maybe they didn't hear it in the consent so we still say to trigger. And the reason for that is it gives us the 4 things are early reporting, early patient and family communication, which allows us to really quickly get in there, have an open and honest conversation with them, tell them that our policy is to be open and honest about things, and we'll let them know what we learn as we learn it, and that we're concerned too. And that's a crucial time for the patient and family, because it's scary for them to be now being taken care of by a team that they don't trust anymore because of what they're questioning. So to have a liaison in there, somebody who's reassuring them that we're caring for them, creates this immediate trust, which is helpful in so many ways. The third thing is care for the caregiver. We all know stories where the leaders thought everything was okay and the clinician felt so awful that there can be bad outcomes. There can be suicides. So we know that's the worst case scenario, but there's lots in between that we want to take care of. So we make sure that the clinical teams are okay and we intervene where necessary. And then the fourth reason we want an early response, which gets to your question, is what we call early learning. And we find that to get in there right away, to do interviews, to be able to capture the equipment before it goes back to biomedical engineering, or, if it's a stretcher that there was a fall with, you want to capture that stretcher, you want to be able to make sure it's operating right and have it be part of the event review. Figuratively, I always like to say, for those of us that have been around a while, we remember how the strips, when the alarms would go off, the strips would just kind of like keep rolling off the monitor onto the floor, and then they'd eventually make it to the wastebasket, and a few strips would be taped onto the chart. But it literally lets us get in there and get the strips out of the wastebasket, so that we've captured everything. And that's that fourth reason, I think, gets at your question about why it helps us get to the truth. Really, we can then combine the two other pieces of care for the caregiver and early comfort and communication with the family, allows us to be asking questions, learning about the event in real time when everybody's memories are fresh. At the same time, we're reassuring them that we have their back and that we're going to make sure that everybody's okay from this. Those are, I think, the most important components for getting in there early. It doesn't mean necessarily that we do a rapid event review. Sometimes the full event review can take a couple weeks because maybe we had multiple specialties involved with the care. It has to go out to 2 or 3 peer reviews to be able to understand standard of care. But getting it started early is what we find is really helpful.
Yeah, I've also understood that you talked about the need for better real-time monitoring in our systems. And so hour by hour kind of awareness of the safety situation in our hospitals. And so I'm wondering what that actually looks like if we did that. I think a lot of people in our audience might be accustomed to knowing about events that happened a day ago, a week ago, depending on their rank, depending on how their hospital works, but certainly a noticeable delay between the event occurring and somebody who might have the ability to intervene to know about it. What would it look like to have hour by hour awareness of safety?
I mean, most people are familiar with the emergence of trigger tools, and I think we're gonna see a real explosion of that in the next few years in a good way, with the ability to use AI and more data coming together. AI is probably not the limitation right now, as much as having all the data that you need in real time available to do modeling on and create the triggers. But that, I think, the ability to do early intervention with patients and the ability to identify early when there's been a potential adverse event or a serious unanticipated outcome allows us to get in, especially to do the communication with family early, is really important. And I think also the other piece when we talk about this that is really important to emphasize is that the real utopia here is not doing early intervention when things are starting to go wrong or when there's been something that's triggered a series of errors or other system factors that can lead to an adverse event. The real utopia is to get to the next level with data and signals telling us where our risks and hazards are before it actually impacts a patient. And I think that's the future. That the 10 years ago, we all thought we'd be there by now. I think it's been a little slow, but it's useful, I think, to talk about how we frame our safety strategy at MedStar Health to put it in context. The way we look at it, we really focus on proactive, and I think we all feel like all of us who do safety in healthcare feel like we spend too many of our resources and too much of our team's time is spent on reacting to events and not enough on preventing future events. And, for systems that use the getting to zero mantra as a goal, it's always important to remember we can like technically you can't get to zero if your only way to learn is after an event, right? That's by definition, you can't get there. So we have modeled our way of framing safety management after the cardiology. Remember cardiology in the 70s, after like the Framingham study and everything came out. Remember the prevention of medical disease framework where they had primary, secondary, and tertiary prevention of heart disease, of heart disease. And primary prevention was like teaching people early on so that they would not acquire risk factors of heart disease, anything controllable, like teaching kids not to smoke, getting people on a good diet, all that kind of thing. That's primary prevention of heart disease. Secondary prevention is identifying people with underlying risks of heart disease like atherosclerosis and other issues, and then controlling that before they have a heart attack. And then tertiary prevention is managing after a heart attack, managing lifestyle and all that. So we use that as an analogy. And we said the way that we want to manage safety is, first of all, we should do primary prevention of safety problems, which means actually designing the system for safety, making sure we're selecting and training people properly, making sure our processes are in place to optimize safety, making sure when we acquire medical devices that safety is a major consideration, and when we implement them, etc. That's creating a framework of a system that is optimized for safety, and we call that primary prevention of safety events. Secondary prevention of safety events is, just like the analogy in heart disease, identifying underlying risk that's in the system before it's injured a patient. And then tertiary is after the event, and that's what I just described, those four things after an event that we want to respond to. Where I think the highest yield is for us in the future in becoming safer as a health system is in that second component, where we have everyone that goes to work every day and takes care of patients in a health system knows where their risks are. We all feel it. We all encounter it every day. And the problem is we're so complacent to that because healthcare is so complex and so fast moving, and we're so good at resilience. People keep everything safe day to day. We're kind of navigating through all the risks and hazards that I think as a health system in this country, we've become complacent about reporting this stuff and really pointing it out. Or it may seem small to each individual, but nobody's capturing the essence of a trend. So I think that's where our future is. If you want to talk about like triggers, using data, we need to take all the different data feeds available to us and train them to start giving us a daily notice of where the risks are that we need to mitigate before we injure a patient. And this isn't just like we all go to where our heads immediately go is our reporting systems. And definitely our reporting system partners out there need to get better. And I think many of them are exploring this in a smart way, is how do they use new technologies to pull trends out. But there's also things like patient complaints, patient feedback, even satisfaction surveys. There's things like IT help desk tickets. There is so much data out there in addition that can give us information about where our risks and hazards are. There's in the biomedical engineering world, et cetera. And you can think of the analogy in aviation. NASA has reporting system that's completely voluntary and protective, that they do a lot of proactive change in aviation before an incident occurs, based on data that they pull out, trends that they pull out of these reporting systems. So I think that's where the most important triggers are. We always think of the triggers of real-time things starting to go wrong in the acute care setting, which I think is important. But where the money really is and where our future really is in becoming ultra safe is in that second stack, that what I call secondary prevention, understanding where our existing risks are and really trying to mitigate them in a smart way.
Yeah, I mean, it's a refreshing perspective just to hear the idea of this secondary prevention. If in some future we're doing the secondary prevention well, does that then free us up or fuel us to be able to do, primary prevention, to design things in a better way from the start or something like that? Is that the ultimate vision?
Yeah. It's an interesting question because we all have limited resources, right? And we have a lot of smart safety scientists at MedStar Health that are involved in safety leadership that understand all of this. And still, we spend a lot of our time reacting, and we all have limited resources. So I think it's a combination of two things. One is you do have to, I think, start to prioritize, and we've done this a lot, prioritize the events we respond to. Not everything needs a full event review to learn from. And by doing that, you can free yourself up to do more of the proactive work, both primary and secondary. But to answer your question, I think for us to get to utopia, we need to really do both. Well, really do all three well, because you have to learn from events. And of course, learning from events means not only the things that contributed to that event, but you always learn about other risks and hazards when you're deep in the event review space. So, but it's also really doing a good job at planning for safety in the first place, and device implementation, et cetera. But as you're pointing out, like the real high yield is figuring out where the existing risks are. To do that, though, kind of leads to what one of my big messages in this podcast would be, once we identify, two things we're not good at in this country in healthcare. One is we're not good at really identifying the true underlying contributing factors when an event occurs. We think we found the answer, but we don't go deep enough and we don't find all the system contributors. But the second thing we're not yet great at is once we've identified a risk or a hazard or something that is a contributing factor to an event, we often don't match up the correct mitigation in a way that is going to create a sustainable and effective solution. And I always think when we've identified a risk that needs to be mitigated, that mitigation has to be both effective and sustainable. Because you can think of ones that are effective, but 6 months later nobody's doing it, so it's not sustainable. You can also think of ones that are sustainable and can be going on forever, but it's actually more work as imagined and it's not truly affecting or improving like we think it is.
Yeah, and that I think dovetails nicely into another topic which I wanted to talk about with you, which is the National Center for Human Factors in Healthcare. This is, as I understand it, a center that you founded and has grown and is doing a lot of great research in human factors. I wonder what you can kind of tell me about the National Center as it is today.
Yeah, well, I'll start with what it is today, and then I think it's a good story to say how it got there. I think it's a good leadership story, actually, in MedStar Health. It speaks well to MedStar Health's approach to this kind of thing. So the National Center for Human Factors in Healthcare is part of the MedStar Health Research Institute. It's a primarily research-driven organization that brings in outside safety experts, people who come from different specialties in safety, but primarily human factors engineering or other forms of human factors, safety scientists, if you will, and combines them and integrates them with clinical experts to bring the two ideas together. And this comes from my background that I described in the beginning. I really saw this disconnect of safety scientists, and there's a lot to safety science, but I had really come out of the human factors engineering approach to safety. And there's a real gap in having safety scientists understand the domain of healthcare, and there's a gap in having healthcare leaders understand safety science. So the center was created in 2010 as a solution to that. MedStar Health put forward a small startup of a few FTEs for a couple years with the promise of being able to build, using grant funding, build a center. And that's exactly what happened. It very quickly grew. It's had over $40 million in external funding. And it's been primarily externally funded as a grant and contract organization that does lots of different projects, all focused on safety and all focused on integrating human factors with clinical work. and I led it. It's been around for about 16 years now. I led it for the first half and then handed it off to Raj Ratwani, who helped me build it. He was my PhD partner. He's a human factors engineer, and he continues to lead it today. And he's also a vice president of our research institute. And the center has had a lot of national influence. I'm very proud of how much we've influenced policy, especially around EHR safety design, but also medical device usability and design and other safety factors in healthcare. But I'm also really proud of how much having human factors engineers and safety scientists embedded in our health system has influenced the way our health system leaders think about safety. And I think that's been a real game changer for us. And here's the leadership story part of it. It's because our senior leaders, from our CEO to our chief medical officer, chief nursing officer, the hospital presidents, people in our system really understand how important it is to aggressively go after safety in order to create a safe environment. And it's been a commitment of the health system for the last 20 years. And it's part of our, what we call critical capabilities in our strategy, is doing everything we can to maintain highest quality and safety. And the investment in the Human Factors Center as an innovation 15 years ago is a good show of that. And it's a good story because at the time, I told you in the beginning about the sequence of my career. I was a safety engineer. Then I went to medical school, did an emergency medicine residency. And the first decade of my career, I spent at the University of Rochester, which had a really good infrastructure for mentoring and developing academicians, particularly in emergency medicine. It was a really good academic emergency medicine center. I had good mentorship. And I built an early program there applying human factors in healthcare. And then in 2010, I needed to move closer to the DC area for family reasons. I shopped it around to all the academic medical centers in the DC, within a couple hours of DC. And most of them were very traditional about, come join our emergency medicine faculty, and, work on your grants, build your center. And MedStar Health took it a step further, and I was selling a vision of within 5 years I could get enough funding to fund a few PhD partners to work with. And MedStar Health said, why don't you send us a proposal on what it would take to start with a few people and where you think we'd be in 5 years if we started with that. And that was this investment. They were interested in innovation and they were interested in highest quality and safety, both as part of their strategic plan. And they saw this as marrying the two. And it's a good leadership story because it really paid off. With that, being able to bring in a couple smart PhDs early on, including Raj, who now leads the center, we were really able to build it quickly.
Yeah, and you hit on a lot of key points that I wanted to ask about there. One thing that came up in our earlier discussions was distinguishing improvement competencies or skills around quality improvement versus safety competencies. And I think this is not always clear to people in terms of, titles, for example, leadership titles. There's a lot of lumping safety and quality and improvement and other words together. How do you think about those as distinct competencies?
It's a great question. And actually, I always like to point out to people, if you're a quality and safety leader, what's your elevator speech if you get in the elevator with the CEO and the CEO says, hey, Terry, you lead quality and safety. What's the difference? I've always wondered what the difference is. It's interesting because I think many of us historically have struggled to really be able to clearly define the difference in healthcare. And as somebody who comes from outside of healthcare and really looked closely at other safety critical complex industries, that was a distinction because in other industries it's really well defined. So one of the early things I did as I transitioned from a academic physician to a physician leader, which that's been my kind of career progression since starting the Human Factors Center, is I really thought we needed the general leader at our organization. Everybody, not just quality and safety people, but everybody needed to understand the difference. So I looked at references, and what we came to is, from a patient's perspective, Quality is really a measurement on how good your quality of care is against a benchmark, and it's a quantitative thing. So I say the easiest way to understand it is from the patient's perspective. Patients say, how does my care measure up against best practice? And quality, clinical quality is something we measure quantitatively. We have a number, we have a rate, we have some kind of number that we can benchmark against other health systems. Safety is very different. Safety is don't harm me. There's so much interaction between the two. Obviously, if you have a safety event that happens frequently, it becomes a quality metric. So these are so interactive. It's always important to say that whenever I talk about the distinction between quality and safety as specialty areas, health equity is a really important other area that flows into both. And that's when the patient says, do I have a fair opportunity to be healthy and to receive high quality care and to be safe? And we build health equity into everything we do in quality and safety. So whenever I talk about this framework, I always think it's important to emphasize that. And the second thing to emphasize is from a patient's perspective, they don't care. They want high quality care when they walk in. If you think of the IOM report in 2001, remember the IOM had this wheel with 6 components to quality, which included efficiency, equity, effectiveness, patient-centeredness, timeliness, and safety. So, and it's okay. From a patient's perspective, high quality care includes all these things, including safety. So when I talk about this distinction, it's really important to say that the reason it's important is not because it matters to the patient. The patient expects high quality, safe care. They don't care about what the difference is. The reason it's important to make this distinction as leaders is the suite of competencies and skills professionally that people need in order to improve clinical quality is different than the competencies and skills that people need in order to ensure a safe environment for the patient. And I think that the conflation, what I call the conflation of quality and safety competencies in U.S. healthcare system, is a big part of the problem of why we're not getting safer fast enough. I mean, there's always debate out there about in healthcare in North America, are we getting safer? Some say we're not, some say we are. I think what we all can agree on is that we're not getting safer fast enough. And one of the reasons we're not getting safer fast enough is most of our leaders in North America whose title is that they lead safety have not had any training in safety, or very minimal. Many of them have had Lean Six Sigma, Plan, Do, Study, Act, like those traditional industrial engineering, process improvement training, which is really, really important and really good for managing clinical quality. Because clinical quality, if you have an outcome you want, like you want to reduce CAUTI or CLABSI, you want to get to the number, you know the standard of care is you need this bundle of 5 things in order to optimize it. It takes really good process engineering to do that. That is different than protecting patients from adverse outcomes from random safety events that can occur. The competencies needed for that kind of work include things like really understanding human error at a Jim Reason or Rasmussen level, understanding the 3 kinds of human error, how do we mitigate each kind of human error, understanding complex systems theory, systems thinking, resilience engineering, human factors engineering, how to put an effective mitigation in place, how to lead a culture of psychological safety and reducing cognitive bias and misdiagnosis. It's a whole different schooling. And one of the things that really struck me, I came upon this kind of slowly, but one thing is I would put out job announcements for a patient safety leader, and I would get resumes from people who would start the cover letter about being a black belt in Lean Six Sigma. But then when you look, they just had no safety training. And I realized that people just didn't understand this distinction. Now, I've talked about this a lot in the last several years. And when I talk about it, one of the reactions that I often get that it's important to address is people feel like I'm trying to separate quality and safety. And so it's important to say that's not the goal. In my job, I do both quality and safety. As the chief quality and safety officer for our health system, I'm responsible for quality, safety, infection prevention, and health equity. And I think I'm good at both. And I have leaders on my team all over the place who do both. The reason they're good at both is because they're trained in both. So I'm not a proponent necessarily of separating it. What I'm a proponent of is if we have people responsible for clinical quality, they need to be really good at process improvement techniques. They also need to understand, by the way, in the US, how they optimize things like star ratings and leapfrog and value-based payment and all that kind of thing. But if they have safety in their title, they also need to be trained in the things that make you good at safety management. And other industries, other complex high-risk industries have embraced this for many, many years. They have often separate quality management departments and safety departments. And again, I'm not advocating for separating departments, but they really do have people who have careers in these different spaces.
Yeah, and certainly important to highlight those because I think, as you've already said, the quality improvement skill set maybe gets a little more airtime. So, and is that something that the National Center is also doing in addition to the research? Is that offering training in safety-related skills, or is that separate?
Yeah, National Center for Human Factors and Healthcare has, for many, many years, we've done training. We do workshops. We'll do basic workshops in human factors. We've also helped other organizations as they do it. We try to be really, we always think collaboration beats competition in every way. And there's lots of organizations around the country that do this kind of training for people. We worked with the Institute for Healthcare Improvement as they were developing a board certification for human factors professionals. We helped develop their curriculum to train, to help people with the review and preparation for the exam. We do workshops on event review training because we're very proud of our systems-based event review that we developed here. Years ago, we were part of the AHRQ Candor grant funding, and Candor is a process that AHRQ developed that includes, there's a lot around early communication with patients and families and the medical legal work on that. What our team, the human factors team and our safety team developed together is the event review program that's in that it's a evolution of the MedStar Health systems-based event review program. And we also contributed very heavily to the development of NPSF at the time and now the IHI RCA squared program, which both the Candor event review and the RCA squared event review, I think really get to this safety competency piece of really trying to do things better and differently in terms of understanding the risks and mitigating the risks.
Yeah, I'm familiar with the RCA2 framework as well. I'll make sure to include links to all the relevant resources that you mentioned there, including the National Center's website. That's great. I mean, I think there's so many other things that we can talk about in this space, but I do wonder whether this is the best place to kind of round out the conversation for today. For listeners who would like to follow you, to connect, how would they best do that?
My most active social media is LinkedIn. It's just simply Terry Fairbanks. That's where I am most active. People are welcome to email me. Also, terryfairbanks@medstar.net. And I don't use Twitter as much anymore. And I'm pretty slow at Instagram, but I'm on there somewhere.
Fair enough. For all of you who are professionally networking on Instagram, you can find him. Very good. Well, thanks so much again, Terry. Appreciate your time so much, Dr. Terry Fairbanks. And this has really highlighted such an important and perhaps under-recognized, underappreciated area within our quality and safety world. So I'm so grateful to you for telling us about Annie's story, for the National Center for Human Factors. So grateful for that. And I look forward to another episode in the future where we can maybe dive a little deeper into even more of these topics.
Great. Thanks, Jason. Appreciate it. Good to talk to you.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.